So what I do is find the centre of whereabouts that pain had come on. And then what I'm going to do is sort of either side of that is almost trace out, a bit like a sort of puddle really, from the middle to the outside, and map out how far that diameter is and what the circumference of that is. The patient or the player will give you feedback regarding how sore that is, and when there's a change in terms of the amount of pain in the area, that's a really good indicator that that's the end of where that sort of bleed will be. So there's going to be an area centrally that's really sore, and then as you trace out laterally or medially, proximally and distally, you're going to get some borders as to where that bleed has occurred. To the touch, it's probably going to feel pretty full, and it may well be pretty sore to palpate as well, particularly with any sort of increased amount of pressure in there. So that'll give you an area mapped out, and then what we need to do is look at the amount of range of motion that player has. So if you bend both your knees as far as they'll go, so what you're looking at initially, if there is some discrepancy there, what's the distance of the heels to the bum? And if one of them is down, so if you drop that one to there, let's say this is the symptomatic side, you measure how many fingers short that heel is compared to the other heel. If that's full and there's no issue, the other thing that you can do is obviously take the knee up. So I'd normally start it out of 90 degrees, take it to 90 degrees, so you know that that is the range they've achieved in crook lying, and then slowly look at taking the bend down there. Now the thing to consider with this is the hip is at 90, so you're actually putting the rectus femoris in a sort of shortened position, so you're just more testing the other quads that cross the knee in this position. So again, you're looking for symptoms that come from the player. Is it feeling tight? Is it feeling full? Is it restricted? Is it sore? And you're going to monitor that range, eyeball what angle the knee's at, and that will give you a nice measure from there. The other thing you can do in this position, if that is fine, is do some resisted testing, if you like. So I would normally hold the leg in this position and then just ask the athlete just to resist that knee extension, and again get some feedback how that feels. Is there a reduction in power? Is it painful? Is it limited? And again, if it's absolutely fine, I'd go into the more inner range in there, and then again get them to push out against me, so I'm feeling for that. If you wanted to take that further, you then almost get them to push you away, so then you're actually allowing that leg to come up into that position up here, and then I'm going to apply an eccentric force, so they're then working their quad eccentrically. And again, you're looking for any symptom reproduction. One of the main tests that I would do, which gives us probably the most indication regarding how long that athlete is going to take to come back from a dead leg, is the knee flexion range in this prone position. So what I'm going to do is almost just passively take the leg into knee flexion, and I'm monitoring the range that the athlete can allow me to get to before they get symptoms. So as I lift up, I'm just looking for some feedback, and I'm looking at the angle that knee is at. So if they can get to sort of 45 degrees and that's their limit, that is indicating there's quite a lot of fullness and a pretty decent sized bleed in the front of that thigh. That is probably going to be associated with longer time scales. And I'm assuming that this is someone who are maybe seeing sort of 24 hours after the injury, or even potentially less if it's filled up quicker, just for an indicator. And then as the angulation of the knee increases, if that's their limit, around that sort of 60-70 degree mark, I'm probably assuming that athlete has got a reasonable bleed in there, and that could take two to 3 weeks for that. If they get to 90 degrees, I'm less concerned that we can turn that around probably within that sort of week territory. So if this happened on a game day on a Saturday, potentially we could turn that round for the following Saturday. But the thing with dead legs is it's a very day-to-day thing, and they all respond quite differently. And obviously if they can get more range in that knee, the level of sort of concern and time scales is usually quite a bit less. The other thing that you can do in this position is obviously look at sort of resisted testing as well. So the more knee flexion that athlete has, the more that you're winding up the front of that thigh. Quite a nice way resistance wise to check this is almost use your shoulder to take that down, and you can control again the amount of range, and then just in that position ask the athlete to push into extension, so they're then pushing into my shoulder. So if you push out, again, you're looking for symptom reproduction, any pain, discomfort, how much output they have. If you wanted to, you could use something like a sort of handheld dynamometer, put it against your shoulder and get them to push, so you've then got another objective marker. And again, as you go into this sort of inner range, and again getting them to push, if they're fine in this range, again, you're probably thinking this is something that is going to settle down and functionally should look better when you then test it out on the field.